Well, welcome. Good afternoon. Great to see so many of you familiar faces and some new faces as well from a wide range of CQC providers too. For those of you who don't know me, I'm Claire Sieber. I'm a GP and I run the Well-Led provider with a team that you will shortly meet, and you can see their faces on the screen hopefully too. This is the first of our CQC Well-Led series of webinars, with each one focusing on one of the quality statements in the Well-Led key question. And we're starting today with shared direction and culture. And this is what we're going to cover today. So we're going to unpick the shared direction and culture quality statement with one of our CQC experts and give examples from recent inspections, good and bad examples. And then our CQC expert will grill our two providers that we have with us today, a GP partner and a former practice manager, on how they'd go about achieving this particular bit of Well-Led. And then I'll talk you through how the Well-Led practice provider platform can help and how it fits in with CQC Well-Led. And then we'll have a chance for some questions at the end. The slides will be circulated afterwards, as will a recording, so you don't need to be making copious notes. It will all be made available to you at the end. So we'll start with some introductions. Gabby, would you like to introduce yourself?
Yeah, thank you, Claire. Hi, everyone. My name is Gabby Ashton. As you can see on the slide there, I'm a former CQC inspector. So I was with the CQC for about 4.5 years, and I now work as a CQC compliance and quality improvement specialist. So working across the health and social care sector from a CQC perspective. So nice to see you all.
Thank you, Gabby. Gary.
Hi, yeah, my name is Gary Hughes. I spent 13.5 years as a practice manager up till 2021. I've been a PCN board member and a founding director of the Federation, but I now work as an associate for the Well-Led practice and support primary care organisations, be that federations, PCNs, practices, with a wide range of things.
Thank you, Gary. Ketan.
Hi, I'm Ketan. I'm a GP partner in West Herts for the past 16 years. I've also been a PCN CD, and I'm currently the locality lead and federation director in my patch.
And fairly recently had a CQC inspection, I think. Is that right?
Yes, yes, only late last year, that's right.
There we are. And then the final two people in the company, me, Dr. Claire Sieber, and my colleague Oscar, who's on the call. He's waving at the camera now. We founded this company about a year ago, and I'll talk to you towards the end about the sort of provenance of the company. But I'm a GP by background. I'm based in West Sussex. I also mediate partnership and PCN disputes. I have a bit of an interest in leadership. I sit on GPC. I've worked for some LMCs in the past, that kind of thing. That's me in a nutshell. Oscar, would you like to introduce yourself?
Yeah, hi everybody. So I'm Oscar. So Claire's a co-director. I'm as you can see on the screen, I think, former barrister, works the GMC Fitness to Practice, but for the last 10 years or so, mediator, coach team development within healthcare, primary care, a lot of the time. Thank you very much for coming, everyone.
Thanks, Oscar. Right, let's kick off then. Gabby, over to you to give us everything that we need to know about shared direction and culture.
Thanks, Claire. Thanks, everybody. Okay, so yeah, as Claire's mentioned, we're going to do a series of 8 webinars across the year, looking at the different elements that sit within the different quality statements that sit within the Well-Led key question. So hopefully those who have joined will be familiar that the CQC have very recently rolled out their single assessment framework. So we've replaced what you may have referred to previously as the key lines of inquiry, and we now have the quality statements. So the very first one that we're going to be looking at is the shared direction and culture. And you'll see here that the CQC have described this as wanting to have assurance that from a provider perspective, you have a shared vision, strategy and culture, and this will be based on transparency, equity, equality and human rights, diversity and inclusion, engagement and understanding the challenges and the needs of people and your communities in order to meet these requirements. So it's quite a lot in one particular area, and imagine we've got to then unpick 8 of these across the year. So Well-Led has always been one of my favourite, but also one of the most in-depth of the 5 key questions. So it's great to have as many of you on the call as we do. So what I've done here in purple, you'll see the different regulations. So there are two key pieces of legislation that apply to the CQC. We've got the Health and Social Care Act and also the registration regulations. So that's, you'll see Regulation 17, good governance. You may be familiar with that if you've ever had a CQC inspection and it's not maybe gone well. You've probably been breached in Regulation 17 because that tends to cover well-led. 90% of the time you'll see that that will be the main driving force from a regulatory breach. But what the CQC have done now is introduce more relevant pieces of legislation into this particular quality statement. So we've now got a real focus on person-centred care, which covers Regulation 9, and much more of an emphasis on dignity and respect, which is Regulation 10. Previously, you may not have seen those as much in well-led, so it's really positive, I think, to see that much more, the focus much more on the patient and as well and the staff, so your workforce, and making sure that inclusion and culture is really well considered. Then you've got the Human Rights Act and the Equality Act. So those are the two bits in green that you can see on your screen. I think it's off the top of my head, it's about 25 out of 34 quality statements look at the Human Rights Act. So within the new single assessment framework, there is a real focus, as I mentioned, on making sure that your workforce and the people that you provide care and treatment for are well looked after, and that equality and diversity is well considered. So we'll touch on that a little bit more as we go through the presentation. And then just really quickly, you've got another, you'll notice that there's two Regulation 12s. That's not a mistake. It's because one is from the Health and Social Care Act, and the one at the bottom, your statement of purpose. You will hopefully be familiar that you need to keep your statement of purpose regularly updated. And then you need to notify the CQC within 28 days of any such revisions that you make. So making sure that if you do change your strategy, if you are having a kind of a rethink about the vision or the direction of travel that your business is operating in, make sure that your statement of purpose reflects that, and then that you communicate that with the CQC. So we'll move to the next slide. I'm not sure we can, there we go, thank you, Claire. So I know that we've got predominantly GP practices on the call with us today, but we have had a lot of interest as well from those working in adult social care services in residential homes. So we've picked a little bit apart from both service types. So hopefully for everyone on the call, you'll feel you get something from this. So we've looked at the sample of reports that were published in January of this year, and you can see that just half of the amount of GP practices were inspected compared to residential homes across in the adult social care area. But nevertheless, we'll have a look. So you can see that in GP practices, we're looking at 71% of the reports that were published this year received a rating of good, and just 1%, so only one service out of 105 actually received a rating of outstanding, which is incredibly low. You don't need to be told that, but it's incredibly low. So, and we're also looking at nearly 30% of the GP practices received a requires improvement or an inadequate rating. And of those that I had a look at, all of them had a breach in Regulation 17 and under the well-led key question. So it's a real driving force for poorly rated services. And then similarly in the care homes, you'll see that just over 50% actually have had a requires improvement or inadequate rating. So that's an incredibly high proportion of services that are looking at a breach from a governance perspective and a well-led perspective. And then just over 40% have received good. And again, a very low number of providers are achieving that outstanding rating. So as we go through the report, this presentation, as Claire said, we're going to be looking at the reviews that the CQC have provided under those 4 ratings. So if we move to the next slide. Great, thank you. So under the, just from a visual perspective to help people, so anything that's in green is an extract from a report that's received a rating of good. Anything that you see as blue is outstanding, requires improvement is orange, and then red is a rating of inadequate, just to help you. So within the shared direction and culture, just to make it more fun from a CQC perspective, there are then a number of elements that sit within that. So it's not just one blanket statement. There are actually a number of kind of subtopics within there. So The first one that the CQC have said that they want to have a look at is making sure that leaders ensure there is a shared vision and strategy, and that staff in all areas, that's really important to remember, that all areas know and understand and support the vision, values and strategic goals, and how their roles will help the provider in achieving that vision. So I won't read all of these out, and as Claire mentioned, you'll get the slides afterwards, but you can see some examples from the report. So staff we spoke to, so from an inspection perspective, we're aware of the vision and values of the practice and of the practice mission statement around providing good patient care and services. That's got a good rating. It's surprising how often, sadly, when we're thinking about all roles, so we're thinking about administrative roles, clinical roles, how often they don't know what the vision or the values of the practice are, and sometimes they can become sort of from a tunnel vision perspective, only really mindful of what their roles and responsibilities are, but not what the wider practice is hoping to achieve. So that's a positive to be recognised by the CQC, and hopefully something you can think about when you're working from a leadership perspective. So if we have a look at the next slide, part 2. So we've got here some outstanding examples. So from the one service that received outstanding in January, we've extracted some of the points there for you. So this looks here at staff and leaders to ensure that the vision, values and strategy have been developed through a structured planning process in collaboration. So the real focus there is on collaboration with people who use the services, staff and external partners. Again, it's very common that you will see a vision being developed from a leadership perspective only. It's then great if they can include their workforce. That's kind of one step beyond that, but even more so, it needs to include your patients. So when we think back to the very beginning, the first slide, it talks about understanding your community and understanding the people that you're supporting at a local level. So this particular element of shared direction and culture really focuses on that for you and drives that home. So the 2 areas that they got outstanding in, they saw that they recognised that new businesses and operating plans were shared and discussed with your patient participation group. It's not something, unfortunately, I've ever seen, so it was really positive that that was achieved. And then also that the results of the surveys and the complaints reviews were also shared with the patient participation group and posted on the practice website for wider access. So again, really thinking about inclusion, thinking about patients who, going beyond that might not necessarily have access to the internet. How are they included in the development of the practice? How do they know what the direction is, what the culture is? Thinking about it from a listening perspective, if they're going to be providing feedback to you, what you need to ensure is that the feedback loop is tied up so that they recognise that anything they do tell you is heard, acted upon, and then they know what those changes have been. So some food for thought there. So if we look at the next slide. Thank you. So this part here, you'll see there's a few in red. So these were from multiple GP practices that received an inadequate rating from the overall, but also from the well-led section. So the CQC here want to know about staff and leaders being able to demonstrate a positive, compassionate, listening culture. And again, I'd say the real emphasis there is on listening, that promotes trust and understanding between them as leaders and the people using the service, and that there's very much a focus on learning and improvement. So one of the examples that we can see from the inadequate rating is that staff reported incidents of public shaming, of staff raising concerns in meetings, and some described not feeling respected and described a negative culture. So obviously that's an incredibly difficult situation to be in for all the workforce if they don't feel able to raise concerns, suggest ideas for improvement, if that there isn't a positive learning culture within the business, if there's no compassion demonstrated by the leaders, then that would obviously lead to a very, very poor rating, and in this case an inadequate rating from the CQC. So it's really important that you're mindful of what the learning and the listening culture is across the organisation. Then if we can have a look at another inadequate here, so learning from complaints and other patient feedback was not used to improve the quality of care. So again, this is a really common thing that I come across as part of a CQC inspection. We talked earlier about the feedback loop, but there's also the learning loop to consider. it's one thing collecting data, and often that's where things can end. So you think, okay, we've done our audit, we've collected complaints, we've got a fancy leaflet at reception, we've got it on our website, people know how to contact us if they've got anything they want to say, but nothing's done with it. So there's often just a collection of complaints, but there's nothing then done to analyse those and then drive improvement. So really thinking about what it is that you're going to be doing with that feedback. And then, as we saw from the outstanding examples, sharing that back with the people who have given it you in the first place. So if we move to the next slide. So some outstanding examples here, both from residential services and GP practices. So this here is asking from a CQC assurance perspective that staff at all levels have a well-developed understanding of equality, diversity and human rights, and that they prioritise safe, high quality and compassionate care. So as I mentioned earlier, the Equality Act is and the Human Rights Act is much more prevalent now under the well-led key questions. So we're seeing much more of an emphasis on person-centred care and dignity and respect that have a focus from an equality and inclusion perspective. So we want to be seeing that when you're talking about shared direction and culture, that has been considered. So an example from a residential home is that staff felt respected, supported and valued, which then supported a positive and improvement-driven culture. So one staff member they spoke with said, outside of work, I've experienced some of my own difficulties, but the support and encouragement I've received working here has meant that I've been able to turn my lived experience into something positive. This in turn has helped me to better understand the needs of the people I support. So that's a really fantastic extract to be recognised by the CQC, and for that staff member to feel comfortable and confident to be able to feed back to the inspector. Lived experience is, it's an invaluable opportunity for leaders to embrace and to embed into the direction and into the culture of the business, and it should absolutely be celebrated and supported in any way possible. So that's fantastic to think about. And if you spin that on your head and you imagine an inadequate or a requires improvement rating for that, it would look something like a staff member expressing that they've got some personal difficulties going on outside of work, but actually there was no leadership, there was no support, there was no compassion, there might not have been any reasonable adjustments made within the workplace, there was nobody there that they felt they could talk to. As a result, they may have either left, which we've then got a whole other issue about staff turnover, or they might have been working but very unhappy. That may have then fed into the culture across the workforce, so other people would become potentially disgruntled, potentially feeling that they can't speak to their leaders and that their management team aren't available to support them. And that if they have themselves got lived experience, which could then support patients in the community, and they're not able to use that, it might then impact on the way that they speak to patients. So patient-facing care might drop, it might become more poorer quality. So there's lots of outcomes that can come from not being an inclusive leader. So that's an important thing to think about. So if we move to the next, thank you. So here again, there's a focus on equality and diversity. So this is much more about active promotion and the causes of any workforce inequality, not only being identified, but then action must be taken to address these. So this goes beyond having a sort of an open door culture and making sure that as a leader you're available and compassionate, but it's actively seeking out and promoting and understanding from an equality and diversion and inclusion perspective. So we've got here from an outstanding service that staff were proud to work for the practice and spoke highly of its culture. That's a really wonderful word to think about, being proud to work there. I think if as managers you know that your staff feel proud to work there, then you've hit the nail on the head, really, haven't you? That's just a wonderful word to hear. So that's positive. And then we've got another example of staff promoting equality and diversity in their support for people. So they understood people's cultural needs and provided culturally appropriate care. And this was a golden thread that ran through all aspects of the service. So again, thinking about a golden thread, that's a really lovely term to hear and to think about from your point of view. equality and diversity and inclusion, it shouldn't just be for one particular quality statement at one particular moment in time. It should be something that we see in everything. When we think about person-centered care, when we think about safe care, when we think about well-led care, there's so many elements, and we should really be making sure that this shared direction and culture is embedded throughout. So again, really positive for them. And then, yeah, so part 6. So we've got some requires improvements here from a GP practice and a residential home. So the CQC here are looking for assurance around staff and leaders can ensure that any risks to delivering the strategy, including the relevant local factors. So again, there's a real focus on the local community, local factors, local knowledge, making sure that they are understood and that you have an action plan to address any issues that come from this. Then that these are regularly monitored and reviewed against the delivery of the strategy and the relevant local plans. So exactly as we've talked about so far, it's one thing having an action plan or having an audit in place, but actually rolling it out, assessing the progress of it, making sure that you're learning lessons from it, sharing those lessons with your patients, with your workforce, with local partners, really wrapping around from a local community perspective is becoming much more important with this new single assessment framework. So it's no longer sort of hiding up in the shadows of working in isolation, but making sure that all of that is shared. So a requires improvement piece of feedback from the CQC was that the practice had a vision. So you've ticked the first box, you've got your vision down on paper, but it was not supported by a credible strategy to provide high quality, sustainable care. So what the CQC are saying there is that you've got an idea how you want things to look, but there's no, you can call it a strategy, an action plan, an improvement plan, a delivery plan, but there was no real way of getting that over the line. So kind of you're halfway, well, you're some way of the way there, but you're not all the way there. So that's why it wouldn't quite be an inadequate rating, because they've got something, but it's not yet good enough to be compliant from a governance perspective. And then another example in a residential home is that governance audits were reflective of current activity at the service, and care records were reviewed before a person received care, and support actions were taken to ensure care records were reflective of the person's care needs. So again, what they're saying is the key word there is in current activity. So they're very much looking at what's happening in the here and now, but they're not doing any long-term planning, any goal setting. They're not looking at outcomes. They're not looking at any potential risks that could be arriving from the care that's being delivered. So having a here and now approach will never be good enough to receive a good rating or to drive your culture and the vision of the service forward, but it will get you through on a day-to-day basis. So that's why the CQC have recognised that as a requires improvement. So if we move to the next slide. Thank you. Okay, great. So that was actually, yeah, so that's the end of the well-led, that particular quality statement, the breakdown of those. The breakdown of those 6 areas. So hopefully when you get those slides, you can have a look at the areas in more detail. And I would always encourage providers, if you ever get any spare time or as part of your business development or your CPD, to just do exactly that, where you can go onto the CQC website and you can actually look at recently published reports. You can narrow it down to your service type. And then you can take some extracts yourself, so you yourself can start building and understanding at quite a present pace of exactly what the CQC are looking for from a well-led point of view. So here we've got a couple of slides about different questions that you can ask yourself, sort of some food for thought. And actually, when Claire and Oscar introduced the well-led provider platform, you'll see that this sort of lends itself to you being able to think about these in a much more fantastic and creative way. But what I would say about this is that inclusion and diversity are often linked. So you'll see it, kind of branded everywhere, and even in the CQC statement, diversity and inclusion. But in fact, it's really important to remember that a team can be diverse, but its culture may not be inclusive. Or you can have a non-diverse team, which might be for multiple reasons, some that you can manage, some that you can't, but it could have a very inclusive culture. So, please make sure that although you're thinking about them together, you're also thinking about them in a separate way as well. And just to kind of bring that home, so diversity is very much about who gets to be on a team, whereas inclusion is about everyone on the team playing a full part in the decision making and the work that's undertaken. So a diverse team could have a wide range of relevant backgrounds and expertise to draw on, but an inclusive team culture makes sure that all of those voices are heard. So when we're thinking about cultural identity, that could cover a range of many things. And when we look at the guidance and set out in the relevant legislation, we can think about things such as age, ethnicity, nationality, or religion. It could relate to a person's sexuality or gender identity, or it could be relevant for people who, for example, are visually or hearing impaired, or who have other health conditions that require reasonable adjustments to support them in the workplace. So again, I won't go through every question on here, but there's 2 slides, so if we can move across to the next slide, and you'll see that there's a number of questions. So questions for you to ask yourself, ask your other, your other partners, other people in the leadership team, ask your workforce. Have you included patients and service users in your process? Are you aware of the concept of HIPPO, so the highest paid person's opinion, or sometimes the loudest people, or the people that may speak the most? They can be the ones that drive culture, drive the direction, but are you making sure that everybody has been considered in the room? How are you making sure that people can contribute to important decisions? So as we touched on earlier, it's not good enough to come to a decision as a leadership team and then let people know that decision has been made. You have to include them in the decision-making process and then let them know what the outcome of that is. Within reason, obviously some things from a management perspective can't be managed that way, but where possible, it's really important to allow everybody to contribute. And then, ensuring that staff and patients have equal access to you. So that's not just a principle, but in reality, day to day in practice. And having equal access to you means that you need to consider how you make yourself available from an accessible point of view. So it's not just having an open door, it's having an open inbox, it's having an open website, it's having a variety of different ways that they can contact you, out of hours. There's all these different things that you need to consider so that there is equal access to you for all different people and your workforce. Thank you. So now we're going to do In the Hot Seat with Gary and Ketan that Claire mentioned earlier. So what I've done is using the feedback that came from the CQC reports is put together 4 questions. So we'll spend about 10 or 15 minutes on these before we go over to Claire and Oscar. And Gary and Ketan haven't seen these questions, so this is the first time that they're coming across these. And this is, from a CQC perspective, I may not ask such an in-depth question, but what I'm doing when I'm doing an inspection is looking to understand the answer to these questions. So you might ask it in 3 or 4 different ways. And also don't forget that from a CQC point of view, they'll be triangulating everything that they report on. So they'll be asking Gary or Ketan as a leader or as a clinician, then they might be asking the workforce, then they'll be asking patients, partners, then they'll be looking at the paperwork and the processes. So this is just one viewpoint, but as a leadership team, it's an important viewpoint. So let's see how we go. So first question to Gary. So in the past, thinking about you when you were working as a practice manager, how have you ensured that information has been shared across the whole team and to your patients, not just to a favoured or fortunate few?
Okay. I think the first thing I would say on that is that not every communication is going to be, it shouldn't be treated the same way. Everyone's going to be treated differently. And I think the starting point is who needs to know. Now, I know often with CQCs, might be a case of there are lots of things that everybody needs to know, but who needs to know? And then I would, certainly the time I was in practice, I would be looking at what's the best way to communicate this. How should I say it? How should this be said? And how should I deliver it? It might be an email, it might be a meeting, it might be one-to-one, but don't treat your communication as the same thing all the time, doing it in exactly the same way. The other thing that I always found is don't overload your communication. it can often be said from staff that our communication's terrible, we never hear anything. But I've often found in my experience that's because people don't find out the things they'd like to know, but they might be finding out all the things they need to know, but just because they don't find out the things they'd like to know, you can often get communication's terrible. So don't do all the same thing all the time. Don't overload people. I think if you overload people, you can start to miss things. So I would avoid doing that. What I did is we were light on meetings. I didn't want to take up time with lots and lots of meetings. We rarely had a full practice meeting unless it was for training, but instead we had focused, targeted meetings. And key were the leadership team. So it would be the partners, myself, nurse manager. But we also had, the practice I was at was a 14,000 list practice, and we had, there was an administration function, reception function, the GP function, the nurse function, and we made sure there was somebody in a leadership role in there, and we had that weekly. And the responsibilities of that person attending it was to filter communication. They made sure that it was, filter's the wrong word, they made sure that they flowed that communication down. So if things were shared in that weekly meeting, then it was shared down, and they had a clear responsibility there to cascade all that information. Now there were other times that something was very important, very urgent, but we also used to use a message tool. We were in EMIS practice, and we had a clear protocol for cascading information that had to go to everybody, very importantly, and then it would be within the EMIS messaging system, or sometimes screen messages if it was that urgent. But we also used to use that as well. There were other times where actually I might feel that I wanted to speak to somebody or speak to a group of people. So I used to then verbally share the information. There were also times, and I think this is probably important for CQC as well, that just because you share a message or you ask somebody else to cascade it, don't assume it's been done. And I would check, and that can be just informally, did you hear about this? What did you think? Or sometimes you might do it more formally, and it might be, have you received, read, understood, actioned? Particularly for CQC, that sort of evidence. So there are times when you might need to do that. Now that's sort of communication to your staff. For patients, it's slightly different, but I think the same principles apply. Don't overload, don't do it the same way all the time. Who needs to know it? Are there target groups of patients? Whether that's disease cohorts or demographics, but who needs to know it? So we'd be looking at who do we send that to, and then how. Again, that's the same principles. Email, SMS, website. How immediate is it that they get this information? Sometimes it can be notice boards, and sometimes it can be when they attend the practice. So we would look at who needs to receive it, how urgently, what's the best way to share it as well. And then there are the wider patient messages that you want everybody to get, and that we may have done through the website. We had just started to use social media when I left, which is another way, but not everybody gets social media. So different ways there, but same principles. What's the best way to do it? How should this be communicated?
Great, thanks, Gary. Yeah, and I think that's really positive as well to pick up on making sure that the feedback has been communicated. So what you don't want to obviously create a culture of mistrust amongst your workforce if you're delegating work to them, and it's thinking about the level of management that you provide, but equally having assurance, especially if you are the registered manager, the nominated individual, having assurance that information has been successfully cascaded, and potentially reviewing it after a certain amount of weeks or months. It might be something very simple that you changed your opening times from 8 to 8:30 and that you think everybody knows, but actually if you do an audit 3 months time, you find that a lot of people are still waiting on the phone at 8 o'clock in the morning, or they're upset that they haven't been seen. So there's ways that you need to then make sure that it has been achieved, but also that it's working, and that people still feel included, and that the service is operating well for your local community and for the needs of the local people. So yeah, that's really positive. Thank you. Okay, Ketan, your turn. So What can you see the benefits are of encouraging staff to take development opportunities that require them to work alongside people who are different from themselves? So this can sometimes be referred to as reverse mentoring. If people haven't heard of that concept, I'd recommend looking it up. It's an invaluable opportunity. But yeah, what are your thoughts about that, Ketan?
So this really comes down to different teams not working in silos, and there is a risk of that when you have, for example, your reception team. You'll have your doctors, nurses, you'll have your secretarial team, and actually they are part of one team. And what needs to actually happen is you want your team as a whole to be greater than the sum of its parts. And there is a risk that if you're working within one team and you're only working in that team, that you will only see things one way, and it can develop into an echo chamber more than anything else. And the risk of that, of course, is that you don't really see things differently. And what you want to encourage is a culture of empathy and understanding. So if something doesn't quite go right, rather than thinking, well, it's gone wrong and it must be because of this, thinking, well, I wonder what's happening there, and having that curiosity as to what happened in another team. And one of the ways of doing that is actually going somewhere else to find out exactly how another team operates or how somebody else works and approaches an issue. And these kind of discussions can come up in your appraisals that you may do with your staff, with their line manager, but really is just trying to maybe pick up ways of working from other people who are not like you, and then you can bring that back to your team. And that's developing that growth mindset approach, which is what it's known as. And that can only improve the function of that team. So when something doesn't go right, you have an understanding that actually there might be a reason, and it's not necessarily the fault of somebody else. So you're trying to remove that blaming culture and bring in more of an inclusive and empathic approach, which is really a very more modern style of leadership, and something to kind of start to develop less of a hierarchy as well.
Yeah, I love that. Thank you. That's fantastic. I think that's exactly it. It's about seeing things from other roles and responsibilities perspective. So, you know, if you are the registered manager and you've got, or practice manager, and you've got your office down the corridor, actually just spend a day, but you've got emails to do or you've got audits to complete, spend a day doing that in a communal space in the reception area, so you can understand what the processes are, what some of the barriers might be, what some of the frustrations might be. You know, you can identify what's going well in the different parts of the clinic. So until you see it and understand it, you can't then improve processes, and you can't then create an improved culture. And exactly as you said, Ketan, it's about taking away the personal blame. It's very rarely a particular individual's fault that something's going wrong. It is usually about a process or, you know, governance structure that's in place. So it's about having that, I don't want to say lived experience, but that understanding from a day-to-day point of view. That's great. So Gary, your turn again. So can you recall a time when you were managing a team or working in a team that was diverse, but its culture was not inclusive? So we spoke about the difference between the two earlier. How did this then impact on how well led the service was? And can you talk a little bit about things that worked well or could have been done differently? Tough question. Oh, I think you're on mute, Gary. There we go.
Right, there you go. Thanks for taking that off. Yeah, I've been reading this, and that it's makes you think, this question. I think, looking back at my experience, and if I think of my time before primary care, I think I've been lucky, actually. I have worked in lots and lots of diverse teams. I think that's probably because of part of the country I'm in, and they have been inclusive. So I found it difficult to find occasions. I can't really think of occasions where it didn't work. So I can tell you why I think it's worked. I think that for me, you know, if you're a leader in the practice, don't forget there will be quieter voices, and they could be quieter voices just because they're introvert, or they may be quieter voices because they may feel they're different and they don't count, their voice won't count. So I think as a leader, you know, don't forget the quiet voices, seek them out, make sure they get a chance to have their say, find out what their views, their thoughts, their opinions are. They may be just as valuable, if not more so. So I think as a leader, you know, don't forget the quiet voices. But I think the key thing for me in terms of inclusivity is role modelling by leaders. You know, if it always has been for me that you treat everybody. Actually, I know treating everybody the same is the wrong way. You treat them equitably, and it's the norm. Expect that as the norm, and you should role model that. So I would always have done that, and I would have insisted that the other leaders in the practice, be it partners or functional leaders that I mentioned before, they role model that as well. And if it's not, call it out. Have that conversation with them so people know it's not right. You know, and I'm fortunate. My experience was it was role modelled. I think you've also got to make sure that that extends to patients as well as staff. You know, any times where patients may have been acting in a discriminatory way or less accepting way of others that did not feel right, I think there should be an immediate conversation with the patient that member of staff knows about, so they knows it's supported, and you are, you know, making sure there's an inclusive culture. So I think those things that, you know, you have to do as well. But I think for me the important thing is it's the norm, and it's the role modelling by the leaders as well. I think that's, if I think back my experience, they were the things that made a difference. Just to answer the other part of that, what could have been done differently? You know, we can always do things better. So I suppose sort of being more open about conversations where people are different or come from different backgrounds, whatever it may be. You know, sometimes we don't have those conversations to explore them, whether that's done privately or, you know, a group, but just sometimes we just think, oh, let's not go there, let's not have that conversation. I'm sure just finding out more about, you know, our differences and our people probably could have done that better.
Yeah, that's great. Thanks, Gary. And I think, yeah, the last part that you touched on about, you know, receiving that feedback and learning from people what could have been done better. If we look back to the outstanding extract that we took about a staff member that reported that they, you know, were having difficulties outside of work, and that their lived experience then actually improved the culture and the working of the business. And there's, you know, that can apply to patients as well. So how are we receiving feedback from them about their lived experiences in the local community, receiving care, not just from your, you know, your GP practice or your adult social care service, but your local partners too. And then using that knowledge to drive change is really important. So we're not just assuming that, you know, you're a patient and that's it, you're all the same, or you're a staff member and that's it, you're all the same. It's really understanding what the different cohorts and the different groups have to say to you about the running of the practice. So last but not least, Ketan. So do you think a reward system works for staff and patients who provide feedback that goes on to shape the service for the better? And if not, why not? And if you do think it works, please expand. It's a tough question, and it's I had a CQC inspection recently that that used a reward system for patient feedback. So I'm intrigued to see what your thoughts are.
Yeah, I think people will have different views on this, depending on their approach to how you want to get things done. It's interesting because actually, I mean, we're using feedback as an example here, but it could actually be anything, any challenge that comes up in the practice. How do you actually get it done? And there is a carrot and stick approach to it. I suppose from a personal level, I don't think that works in the long term, and that's not sustainable, and actually can create quite an unhealthy environment if you're actually going to go down that route. Another reason, and this goes back to my previous answer about having empathy for why something may not be done, for example. Have a look at that and really try and peel away the layers and go, why is that person, for example, not answering the phone as much as anybody else in reception? The assumption, and kind of recognize your assumptions that it's actually, you've just assumed that they're lazy or they don't want to do it. Actually, you need to get to the bottom of this and find out what motivates that person and what is going on with that person. And actually, if you're looking for feedback in this case, if you don't get any feedback or you get minimal, well, why is that? You really need to look at yourself and go, maybe you are coming across as somebody who is not in a position to receive that feedback, because you might respond negatively and people are concerned about that. So if people actually feel engaged with you or patients as a practice, they'll want to give that feedback, because perhaps you've shown that you've taken the feedback on board and actually made the changes, or at least spoken about it and communicated that this is why it can't work, but maybe we could do this. So really, it's about finding the motivations to actually get that. So you need to, if it's appropriate, build those bridges, and you can only do that by asking the questions.
Yeah, absolutely. Yeah, I completely agree with that. I think from my perspective as well, the reward systems that I've come across, I don't necessarily agree with them. And as cheesy as it sounds, the reward should be that you have a better service or that you have a better workplace. So the more that you give, the happier you'll be as leaders, the happier your team will be, the happier your patients will be. So it's not a particularly tangible reward. Well, it is in many ways, but it's not the same as an Amazon voucher or a £10 ticket at the end of the week. But it is something that you will see, it has much more longevity to it. So yeah, I would agree with you in that sense. Okay, so that's it for the thank you both for that feedback. That's been really, really good, and you passed the inspector test. So I will hand over to Claire and Oscar to introduce the well-led provider in more detail.
Thank you, Gabby. Yes, well done, Ketan and Gary. You survived the burning hot seat there. Congratulations, you can relax. So just a few minutes now before we head off, we need to tie all of this in together now and explain to you what the Well-Led Provider platform gives you that's sort of relevant to what we've just talked about with Gabby, particularly this kind of golden thread, if you like, of listen, 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 make sure you're asking, make sure you're listening, then make sure you're asking. Complete the loop, learning loop, feedback loop, complete. And that's what our platform does indeed offer you. So as I said at the beginning, we founded the Well-Led practice about a year ago now, although the platform itself had already been running for about 7 years and has an established base of large organisations that use it to support their leadership and workforce development. Public Health England, now UKS, HSA, Imperial, King's, Red Cross. And as you can see from those statistics on the screen, it's proven to be very successful for them in their team and leadership development. And we now have over 80 PCNs now actually using the platform, and we're offering it out to care homes too. And what the Well-Led provider does is it offers the same service, but with a few tweaks, so that as well as being a great resource for team and leadership development, it also allows you to demonstrate and work towards all of those quality statements that we're going to cover in our webinars within that Well-Led key question. So the usual process that our users of the platform go through is one of this, a cycle, like Gabby was alluding to. So you can set up diagnostics on the platform if you like to get a sense of how you're doing and where things can be improved. There's no other way of finding out if your staff feel supported by a leadership team without actually asking them. And as we've seen, you need to be asking, and listening. The CQC expects you to not only seek the feedback, but also to be acting on it. So if you were to create one of our diagnostics, then your team members will receive a simple link in an email that they can click on to give some feedback anonymously and quickly, mainly by using smiley faces, which then feeds into a very data-rich report that you will get as the owner of your organisation, of your report, which breaks down the responses of your staff member, comparing the views of the leadership team with the views of the rest of the team, comparing your scores with other organisations' scores within our database, so you can get a general sense of where you're at. The report will then highlight areas for you to develop on, and the specific areas that your team members feel are the absolute priority to be worked on first, so you can be confident that you're working on what is most important for them. We then give you recommended exercises and guidance from our big library of resources that has been built by academics and contains all sorts of useful tools so that you can get on and make the improvements yourselves. From that, you can then populate one of our action plans, do another review in due course to show that you've made those improvements, that they filter through and then have become embedded. This is all the stuff that the CQC will want to see you doing. So specifically when it comes to shared direction and culture, which is what we're covering today, we ask your staff the following questions, such as, I feel positive and proud to work here, one that Gabby mentioned earlier, so important if staff feel proud to work at your organisation, then clearly you are doing something right, and that's a really good measure of how your leadership is doing. But there are other questions that we can ask as well. Are your opinions valued? Is your opinion taken on board? Do you feel everyone is treated equally? Quite difficult questions potentially to be asking staff, but ones that if you don't, somebody else will. And then here's an example on the right-hand side of some of the exercises that we have that you can get stuck into on your own, either individual or group exercises to start tackling this if you think that this shared direction and culture is an area that you need to be developing in. This is our price list for primary care. It's based on the number of patients you have in your list, whether that's a practice list or a PCN list. We have a slightly different pricing structure for other providers, such as care homes, which is based on the number of staff that you employ. But it's essentially an annual package where you get unlimited access to the platform. You can do as many individual and organisation-wide reviews as you want. You can use 360s for appraisals. You have full access to the library of guidance, and you have our CQC tools to help you. You also are supported by one of our lovely associates who is on the call today to help you get the whole process embedded in your organisation and to make sure that you're getting the most out of the platform. If you want some more intensive support from our associates, then we can offer to give you some face-to-face developmental sessions on top to complement the work that you're doing yourselves. If you're not sure whether it's right for you, I remember you will get these slides, so you don't have to click on the link now or scan the QR code. We do have a little demo of the platform where you can do a quick assessment of your own leadership using a similar interface to the one that's on our platform, and it will then give you a free resource and exercise to go away and do, depending on what you identify in your self-assessment as an area that you'd like to work on. So that gives you an idea of what the whole user experience is like of our platform.